Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about osteoarthritis. When I left off last week, I got into the details of the incidence of osteoarthritis, why the incidence is so high, and the mechanisms of how the disease osteoarthritis develops, etc. In this segment, I'm going to continue to say a few more things about that, and I will begin the evaluation of someone who presents with the symptom of osteoarthritis. Before I do so, however, I want to take a few minutes of your time to go over this book with you that just came out, The Best of Medical Oncology and Clinical Hematology. This book deals with all cancers of all types and also all blood diseases of all types. It's all super modern, 21st century, high class, academic medical oncology and academic clinical hematology. Take a look at it, and I hope you enjoy all the stuff that I have described and talked about in this book. I, in fact, dedicated the book also to all people in this country and across the world who are suffering from cancer and who also have survived cancer. I'm a cancer survivor myself, so therefore I had to dedicate this book to all my cancer survivor colleagues out there in this country and across the world. Take care. Now, osteoarthritis. Well, osteoarthritis is a very common problem. In fact, I dare say that osteoarthritis is among the most common diseases in the world. Hundreds of millions of people suffer from osteoarthritis. The reason is because you can't have certain diseases, as I mentioned last week, without suffering ultimately from osteoarthritis. I want to give you one last example and I'll move on to the evaluation of it. For instance, sickle cell disease, one of the most common treatment for sickle cell disease to this day is blood transfusion. Thalassemia major, one of the most common treatment for thalassemia major across the world, of course, is blood transfusion, and several other major hematological diseases that results in hemolysis. The reason that blood transfusion itself will ultimately become associated with osteoarthritis is because you're getting all this blood, and all this blood is loaded with iron. Each unit of blood has 250 milligrams of iron in it. So secondary iron overload, therefore, is one of the most common associated problems with sickle cell anemia, beta thalassemia, etc., etc. Yeah, these people do get themselves packed up with iron that the hemolysis itself causes, but they also have to be transfused. So that transfusion adds to the iron overload state. And then the more iron that sits in the body, including the joints, you ultimately have to degrade. The iron cannot sit there. It must degrade, as I mentioned before. And the process of degradation of the iron must, by necessity, produce free radical. And the free radical then begin the process of inflammation. So that inflammatory process, then that's the beginning of the damage that's going to be done to the bones and the joints and the ligament, etc. So that's how these diseases, of which there are millions of them across the world, all hematological diseases, that's how osteoarthritis become high on top of the list of diseases across the world. Not just the aging process, that's part of it. Not just trauma, that's part of it. Not just occupational processes, such as playing sports of different types, professionally or for pleasure, etc. All those things contribute to osteoarthritis. So therefore then, when one understands the mechanism of diseases, it's not good enough to talk about diseases. You must also understand the mechanism of diseases. When you evaluate the mechanism of diseases such as osteoarthritis, which is so common, then you realize, oh my God, this is really much more common than previously thought, okay? So now, Let's talk about the symptoms. The symptoms of osteoarthritis, of course, are pain, swelling, restriction of movement of certain joint, severe the joint. No, they're not only swollen, they're also very tender, extremely tender. And of course, you have the formation of fluid also, because the irritation and the inflammatory process can lead to effusion. The effusion can pile up into the joints, regardless which joint it is. Okay, and sometimes that can become complicated. And as I talk about evaluation, you will see how complicated it is for one to properly evaluate an effusion, because you might be full. You might think the effusion is due to just the joint rubbing itself, causing a local inflammation, which then can cause fluid to accumulate. That may very well be, but you could also have an infection. Okay, so and it may be some another disease. Maybe the patient may have gout. That can also cause accumulation of effusion and so on. So when you see effusion, it's not just that simple to say, oh my goodness, this is the osteoarthritis that's causing the effusion. It may well be, but it could be something even much more dangerous than just the effusion that results from the osteoarthritic process. So the patient comes in, he or she complains of the pain and lack of movement. The pain can be very severe at times, very debilitating. In fact, the most common disease that causes disability in adults in this country and across the world happen to be osteoarthritis. How about that? More people take time off from work because of problem associated with osteoarthritis than any other disease in this country and across the world. Extremely expensive because of that. So therefore, it is a serious problem. So the patient will complain with the pain, will come in, then you have to evaluate it. Very complicated. Sometimes the patient, as I said last week, come in with severe headache. Well, somebody comes in with severe headache, you can't attribute it to osteoarthritis. You got to make sure the person they have a tumor or some of the processes in the brain that can be causing the headache. They may have an aneurysm that's beginning to burst, and so on and so forth. Or they may have AV malformation that's beginning to leak little blood in the brain, etc. So you have to do that evaluation. But when all that thing comes back normal, your CAT scan is normal, your MRI of the brain is normal, or MRI is normal, then you must realize that it may indeed be osteoarthritis of the cervical spine. One of the most causes of headache, besides migraine and all the other stuff, in fact, turns out to be osteoarthritis of the cervical spine. Very common. People comes in with severe back pain, having pain running down the leg. The pain may not be, they may not feel the pain in the back, and yet it's going down the leg all the way down, and that's called sciatica. Well, the most common cause of sciatica happens to be an herniated disc that's pressing on the sciatic nerve. Patient comes in with problem with poor sensation in their hands and their shoulders. Okay, well, that may very well be impingement of certain nerve that causing the person to be having all this problem moving their fingers, etc. Sometimes the fingers are arthritic themselves. They become malformed. These are very common problem, okay? So depending on which joint is involved, then of course you begin a process of examining the patient. Once you finish with your examination, then you got to make sure that there is no neurological deficit. But sometimes the joint that's causing the problem can also lead to neurological problem associated with the bone degeneration as well. So those things are, you have to keep this in front of my mind to check all this stuff out. Now that you've done all that, the simplest thing you're going to do for those people who have x-rays in the offices or whatever, you could do a regular plain x-ray of the joint that's involved. People have spears under their feet, the x-ray can show that. The simple x-ray can show that. People have a fracture that results because of the constant wearing of the bone that can cause them to having the pain. Then simple x-rays can show that. Orthopedic physicians whose specialty it is to deal with this kind of stuff, and rheumatologists who also deal with this kind of stuff, and general internists such as myself who also have to deal with this kind of stuff, because the patient will come to us first, and sometime, of course, after we think what's going on, we would order the x-ray or order the CAT scan or the MRI and so on. Then we'll refer the patient to the orthopedic doctor, because you have to remember, and this is something that's hard for people to comprehend, your responsibility is not over just because you're referring the patient to someone else. Therefore, don't take the chance. You may not see that patient again, and yet you may have missed the diagnosis. Take the time that is necessary yourself to evaluate the patient completely and thoroughly. And when you refer the patient, you're referring the patient to the rheumatologist or the orthopedic doctor with all the necessary tests having been done already. Believe me, you have to do that. Don't think just because you refer the patient, there's no guarantee all this stuff is going to be done. And if it's not done, then you got yourself, you're part of the problem. Because you had your hand on this patient, you examined the patient, and you took it for granted, thinking that so Dr. X or Dr. Y was going to be X, Y, and Z. Most of the time they will, but sometimes they don't. And then something happened, a complication developed, your name is still attached to it. Okay? Never, never, never refer a patient out of your office to see someone else without you yourself done all that you could have done. Even though you may have suspicion what the diagnosis might be, order the test yourself. I know it is very difficult because you have to fight with insurance companies and HMOs to get them to approve certain things. It pays to do it because you don't know that individual X or Y individual doctor is going to do it. And then God forbid something was not done, your name is still attached to it. You're not out of the woods yet. So now you do your complete physical examination. If the x-ray is available, you do something quick and fast. Then you're going to evaluate by doing some blood tests. What are the blood tests you're going to do for somebody who's having joint pain, bone pain? Okay, so we do a complete blood count. In addition to the complete blood count, you're going to do a complete chemistry profile, complete metabolic profile. Make sure you include a uric acid there. Make sure you do a citrate. Make sure you do a rheumatoid factor. Make sure you do an ANA. Because these tests, remember what I said in the past, and I'll say it again. For every lock that exists, there's a key. Either those fancy numbers people use these days or the old-fashioned key to open the lock. If you know those keys, you will not miss diagnoses. Nobody is perfect, but if you know the keys, if you can have, let me give you a classic, simple example. No way can you have an acute infection in a joint that's causing pain, or a flare-up of an inflammatory process in the joint that's causing pain, and have a normal citrate. That's not going to happen. It's only going to happen for the students and others who are interested in academia that's listening. The only condition that can cause somebody to have those inflammation and infection in the joint, we're talking about joint, and still have a normal citrate, the person must have zero fibrinogen. Yes, there is a condition called aphagocytonemia, that is people who have no fibrinogen, because the phase 2 reacting protein that causes citrate to react, please write this down in case you didn't know, happen to be the fibrinogen. That is correct. There are thousands of phase 2 reacting proteins in the human body. The singular one that will cause the celluloid to react, it happens to be the fibrinogen. So therefore, if you were born without fibrinogen, such condition is very rare, but to be complete, I mentioned it. Other than that, the celluloid is going to become elevated. So right away, that raises the red flag. You must explain why the celluloid is high. You must explain it. So your celluloid is elevated because there's an inflammation in the joint or an infection. Then you do a rheumatoid factor to make sure it's not rheumatoid arthritis, because the arthritic symptom could be rheumatoid factor. Doesn't necessarily have to be osteoarthritis. And you do an ANA. Why is the ANA so crucial? There's a condition called mixed connective tissue diseases. Let me repeat that, mixed connective tissue diseases. Meaning that you may be having arthritic symptom, and yet there may be 2 or 3 rheumatological diseases that are of an autoimmune nature that is associated, that's causing you to have the arthritic pain. The arthritic pain may not just be arthritis. It may be other, even more serious conditions. But all these other serious conditions, all of them, individually or in combination, will cause the ANA to become positive. How's that? So that's the basis. This is the key reason you do the ANA. That's the beginning of the evaluation of these processes. You got a long way to go. Because if the ANA comes back positive, then you got some work to do. I'm not going to sit here and bore you, tell you about how to go about that. I will, because I'll be talking about other rheumatological problems later on in the show in weeks to come, because this is a series. You know the way I do things. I do things in series. You have plenty of time, believe me, plenty of time to learn how you evaluate rheumatological problems that are of an autoimmune nature. You'll have plenty of time to learn this. It's packed in all this book. There's section, several chapters here, at least a dozen chapters dealing with rheumatological diseases of different types. And in this book, The Art and Practice of Modern Clinical Medicine and African American Women's Health, chapters, at least 12 chapters on either one of these books. But since I'm not in the book selling business, you may or may not be able to get access to these books. Suffice it to say, got plenty of time. I'm in no rush. I'll be spending weeks, several months, talking about rheumatological diseases that are of an arthritic nature. So you got just be patient. Right now, let's stick with just osteoarthritis. So you do that basic evaluation, the celluloid, the rheumatoid factor. You do the ANA. That's one category that you have to deal with. You did do a uric acid. You did the CBC. Okay, so you're getting somewhere. You do a urine analysis. That's crucial, because there are rheumatological problems that may be coming from kidney failure. As I mentioned before, kidney failure has a way of causing pile of iron in the body, and then that in turn can be why the person is having this problem, which then you go ahead and do a ferritin level. You must do a ferritin level. Yes, you must do a ferritin level. And then person shows up in your office. You don't know who the person is, but you're looking at them. You want to do patient-oriented medicine. You have to do a hemoglobin electrophoresis. You must do it. Don't think that you're going to do hemoglobin electrophoresis only in someone who is black or Latino. Yes, but you must do it, okay? Because let me tell you something. Hemoglobin electrophoresis is a broad spectrum test That includes a whole lot of folks. A whole lot of folks. There is no ethnic groups in existence that doesn't have abnormal hemoglobin that can be picked up by the hemoglobin electrophoresis, regardless of the ethnicity. Some more than others. But white folks, believe it or not, can have sickling disease. How about that? Because sickle cell D, people, which is seen mainly in white, can sickle, and so on and so forth. So do not miss anything. So you do a quantitative hemoglobin electrophoresis. So at the very beginning, every single individual that I have ever put my hand on in my office that comes in that I agree to take care of, across the board, always have a hemoglobin electrophoresis. And you have no idea how many times, years later, issues develop. And I will go in my old medical record, find those piled ups of chat, and in the center of this chunk of paper, because I write everything in my hand, there was a hemoglobin electrophoresis right there. And that solved the problem. That opened up the door right there. Because X, Y, and Z cannot be because there's a hemoglobin electrophoresis. And it was normal. I did it 25 years ago, okay? Or 30 years ago. Because that's the way one practices quality, patient-based, patient-oriented type medicine. You must, dare not, ever discriminate against anyone for any reason. But clinical medicine is a fantastic profession. But you must know how to do it. So therefore, you do your hemoglobin electrophoresis, you do your complete metabolic profile, you do your CBC, you do your urine analysis, you do your saturate, you do your ANA, you do your rheumatoid factor, you do all that stuff, you do your ferritin. So you're looking for everything. Because if the person have primary hemochromatosis, the ferritin is going to be high. See, if the person has secondary hemochromatosis, the ferritin is going to be high. Right away, that raises red flag, okay? Because you would have already done the hemoglobin electrophoresis. So that will package in to evaluate why is that? Why is the iron is high? You have to explain why the iron is high. Because you know now that the high iron can cause you to have osteoarthritis, but you would have done that up front. You have to know how to interpret stuff. It's not good enough to just do it. You have to be able to interpret it. All right. You get all this stuff out of the way. All that is done. You could, at a glance at the bedside, take the sheets what the computer gives you by doing the blood count. At a glance, one glance, you could see if the patient have an abnormal hemoglobin or not. How about that? As you're looking at it right there, you see that the patient's red blood cell is 6 million. And you look at the hematocrit. The hematocrit is 4 million. It's 40. But right away, you got yourself a problem. Right away at the bedside, you just glance at it. Because the MCV is going to be low. But it's not because the patient have low iron. It could be, but that's not why. Because look at, the red blood cell is 6 million. The hematocrit is 40%. Well, for every 10% of the hematocrit is equal to 1 million of the red blood cell. So right away, by glancing at it, you have erythrocytosis with microcytosis. The RDW is going to be high as well. Right there, that is the red flag. Right now, you're onto something. Because you know this patient, by necessity, must have an abnormal hemoglobin. Which is about how are you talking about erythrocytosis with microcytosis and you're discussing osteoporosis? You bet I am. Because I just diagnosed an abnormal hemoglobin. That's right. because there's only one single formula. And I've been at this for 47 years. I'm looking for a second formula. I haven't found one yet. One formula that exists in the field of clinical medicine. And that is this formula. For every 10% of someone's hematocrit, HCT, is equal to 1 million of the red blood cell. And every time that person have 500,000 plus above what it's supposed to be, right away the red flag goes up. It doesn't have to be the 2 million difference. 500,000 more, right away, you know, you have erythrocytosis with microcytosis right away. Right away, if you understand academic medicine, you know the next step. As a matter of fact, I'll tell you something. Every single examination, whenever you're taking your board exam, of all the questions they're going to give you to answer in hematology, they're always going to show you, I'm telling you this, they're going to show you erythrocytosis with microcytosis. And they're going to ask you what is the next step that you do, next test. Because you know what? One of the ways they evaluate you, they don't want you to do too much tests, costing too much money. That's bad. That's the way the boards are set up. But if they ask you what the next step you do, just check the one that's the quantitative hemoglobin. That's the right answer. It's very funny because for many years, when I was teaching at Montefiore, I was one of those that were chosen to prep intern resident, that's what it was, to help them prep them for the board. Not a single time. Every time I was teaching, the resident will take the board. They'll come back 2 days later. They will say to me, "Oh my God, Dr. Alcena, at least 25 questions I answered based on what you told me. They were all correct." Sometimes that's what it takes to make the difference to pass the board. I'm not unique. Many of us were chosen to prep our residents that were getting ready to go and take the board. So if you understand that, every single time, that's what I'm talking about. There's always going to be a question that's going to show you erythrocytosis with microcytosis, and they're going to ask you, what's the next test that you do? And of course, the test is going to be hemoglobin erythrophoresis, quantitative. That's the right answer. And that's how there's a connection between hemoglobin erythrophoresis and osteoarthritis, because everybody who have normal hemoglobin will ultimately develop osteoarthritis. Listen, I'm going to stop here. I'll continue next week. Until such time, keep watching the show. It's Dr. Alcena saying so long. Bye-bye.